Hi, welcome everyone. Welcome to the MI in Africa webinar series. Okay. So we've seen the attendees join us now, so that number is going up.
Awesome.
Welcome, Angie. Welcome, Wangi. Salima, welcome. Okay, so they're joining us thick and fast now.
We should have prepared a dance for this moment while we were
You've got a welcome dance, a welcome music. Welcome all. We're just waiting as all the attendees arrive in our webinar.
Hello, Abera.
Hi, Abera.
Abera, you're with Ethiopia, right? I can't keep track anymore.
Yeah, it's from Ethiopia.
Ah, okay. Angie will be guided by you in terms of when we can get going.
So welcome everyone. So we've got 15 attendees in addition to our 13 panelists at the moment. Just to remind you, this webinar will be recorded and we'll make it available to everyone who registered. There may be some who are not able to join us for the live webinar who would like to catch up afterwards. Okay, so we're up to 16 and 3 minutes past 3.
Maybe we should get going.
Yeah.
All right, cool. Hopefully we'll have some more folks join us. We can certainly all understand Zoom fatigue. So we certainly hope people will also catch up on the recording. So yeah, welcome and thank you for joining us for the third episode in our series, Motivational Interviewing in Africa. What you've got on the screen now, all our panelists from across the continent. We've got some folks from Ethiopia we'll introduce in a moment, some folks from Uganda, and some folks from South Africa. So all the folks that are joining us have done some work in capacity building around motivational interviewing on the continent. And so we'll learn some lessons from their journey and see how that feeds into how we think about motivational interviewing going forward. This webinar is hosted as a collaboration between International Technology Transfer Center South Africa, Motivational Interviewing South Africa, and MI and beyond. So thank you for joining us. Steve, Bill, any words of welcome from your side? You're on mute, Steve.
And so was I, yes. So pleased to see everyone joining us. It's very exciting.
Yeah, no, thanks, Goodman. Looking forward to the exchanges.
Thank you. So what's different about this particular episode of our series is we're really focusing on the research for the first time. Previously, we've spoken about the experience of folks who've received training and how it's changed their practice. We've spoken about the journey of why it is important to talk about MI on the continent. So now we really get to grips with the research. So what's going to happen now is our panelists are going to switch their cameras off and we'll just stay online with the folks from Ethiopia. So the folks in Ethiopia published in 2018 a paper titled A Multi-Site Community Randomized Trial of Community Health Workers to Provide Counseling, and support for patients newly entering HIV care in rural Ethiopia. And so in this paper, they describe the study design and baseline implementation. So I think what we're really curious about, Ellen and Tibebe and team, is who are you? Why did you become interested in this area? And can you maybe just talk us through who all is on the team?
Sure, I can start out, and I'm really will give the great portion of the presentation to my wonderful Ethiopian colleagues. So basically, first of all, thank you for the invitation. We are delighted to be here and really appreciate the opportunity to share with other colleagues who are doing this important work. So in very brief, and then I will introduce my colleagues. This was a 36-month community randomized trial of HIV positive community support workers. And our primary outcome was to help promote retention and care. The study was conducted in the southern region of Ethiopia at 32 district hospitals and health centers. And for purposes of the intervention, we trained and implemented, as my colleagues will tell more about, 71 community support workers. The community support workers were all persons living with HIV themselves, and the participants in the study were all HIV positive patients who had newly entered HIV care, because we felt that those were the people for whom retention and care and loss to follow-up was the greatest challenge. The community support worker responsibilities were HIV education, very relevant to this seminar, counseling and social support, and they'll talk more about that. And also they had liaison with the HIV clinic, so they could contact the HIV clinic nurse and help to coordinate any medical concerns that came up. As my colleagues will talk about in more detail, we conducted an initial 2-day training for all of the community support workers, and the support workers also received regular refresher trainings. And as we'll talk more about, the training included counseling principles for people living with HIV, motivational interview based on non-judgmental approaches. Plus, we also did some group exercises, some practical scenarios that the support workers were able to participate in. And also they met to discuss counseling and other challenges that came up in working with clients. So with that by way of introduction, let me introduce my wonderful colleagues who really
Alan's signal is failing him today. Maybe Tibebe, you can go ahead and introduce your team from your side, and then Albera can come in as well. Oh, there's Alan is back.
Good.
Yep, there we go. So my three colleagues are Tibebe Shinyai, who is the country director. The organization that we worked with was called NASTED, the National Alliance of State and Territorial AIDS Directors. And they have subsequently formed an independent research group. Dr. Sally Workney, who was the ART and clinical coordinator for NASTED, and then Abera Halamichael, who was the project coordinator for this study as well. So with that, I think I'll turn it over to my three Ethiopian colleagues, and they can describe a little bit more about the training and the support worker.
I think before the colleagues come on, in a moment when my colleagues follow on with us, they'll definitely ask more questions about that. I think what we are really keen to understand is who these colleagues are, and how they became interested in this work.
Sure.
So their background. All yours, colleagues.
So
Yeah. Good. Shall we continue from our
Yeah,
side?
we actually become interested in the project. In Ethiopia, there was higher loss of patients from follow-up and HIV care, and we noticed in the meantime that patients usually have problems beyond the health facilities, and that is why we employed these community support workers who actually provided support to the patients within their village, and that has actually attracted us to do and conduct such a project.
Thank you very much. Steve?
I'm very struck by the focus and the scale of the study and of this work. And it strikes me as ambitious, very well focused on an area of high need. So I'm very interested to discover how these community support workers actually got on. I know you'll talk about the findings, but I'm very interested in their experience of motivational interviewing, good and bad, so to speak, because it's a tremendous study. And I've worked quite a lot in the HIV field, mostly on the pediatric side in Africa. So I'm all ears, guys.
And Steve, just to give you a quick background, we're currently analyzing the data, so we don't have the final results, but we thought we would spend most of the time addressing exactly the question that you're asking, is sort of how we set it up, the training and implementation. So hopefully we'll address some of those issues.
Thank you. What next, Goodman?
So what will be next is sort of, and I think they've sort of already outlined, the issue that they were targeting in their investigation. So that's great. I think that what will follow next for us is to know, how they then went about doing that. So I guess, Ellen, this is going in a bit more detail about your, your project processes and, how you've designed the intervention, the steps you followed, and sort of the lessons that you learned along the way. And Bill,
well, at this point, I think I'll just turn it over to my Ethiopian colleagues who have organized exactly.
Perfect. And then Steve and I will disappear, and Bob and Bill will appear and follow-up question there.
Is it Abera we're waiting to hear from, or Tibebe? Tell us about what happened.
I think Abera is on mute.
You need to
So we have lost for sometimes. We didn't hear you what you said for the last minute or two.
Oh, I see. So we just wanted to get a sense. I think Abera is talking, but he's on mute. Maybe he's not aware that he's on mute. We just really wanted to get a sense of, the project itself, how you went about it, how you designed the intervention, the processes you undertook to design the intervention, and then rolling it out. So if you could just take us through the study design, basically, and then Steve and I will fall back a little bit and allow Bob and Bill to ask you the follow-up questions from there.
I think we actually started this project one of the southern parts of Ethiopia where there was higher losses of patients to follow up. And we actually, initially we did a facility assessment. And in addition, we did a community assessment where we noticed that patients would have challenges with their treatment beyond health facilities. And these challenges were actually noticed within their communities or villages. And that actually initiated us to conduct a one-year follow-up of patients with these support workers. These community support workers had long years of experience in educating patients based on their HIV positive status, and that has created actually confidence and positive attitude in their thoughts, so that they used actually to volunteers for many years before our project, and we were able to recruit the better ones from those people, and these people actually were members of PL-HIV associations within their communities. And finally, after 1 year of follow-up of patients by these volunteers, we noticed that there were significant changes within patients who were taking their antiretroviral therapy. And that led us actually to think about to conduct a community trial. And that is why we conducted these randomized community trials.
May I ask who was doing the follow-up interviewers? Was that the community support workers?
Actually, we did have a project coordinator in the region, and there were also project officers within clusters of health facilities. You know, the study sites were district hospitals and health centers, and there were project officers who used to conduct the interview, and at the same time they used to support to provide support to these community support workers. They give them refresher training, and they also used to supervise them, and monthly they conduct a meeting, and in that meeting these community support workers actually present their experience, and they exchange what they came across with during their sessions and contact with the patient clients. And in addition, during the monthly review meetings, there were also some nurses from hospitals where they can make some questions in order to give them some sort of education where the support worker have some doubt. And that was how they used to do that. Therefore, the project officers, on the one hand, they conduct the interview with the clients, and on the other hand, they provide support to these community support workers and they supervise them. They actually not only did have meetings, but they could also communicate through mobile phones. Each support worker used to have a mobile phone, and they can call to the project officer anytime they want to do.
Thank you.
I'm just wondering, Abera, do you want to add?
Pardon?
The sound is also quite poor here. Abira, I don't know if you can hear me. It might be good to turn your video off because the connection the bandwidth is low, and we might be able to hear you better if you turn the video off.
Okay. And Bill, while Olivera is turning off, just to answer, I don't know if one of your questions was how we assessed the effect on the clients, but we had about 1,800 clients in this study. And the primary outcome, which was retention and care, was assessed by looking at the HIV clinic records to see whether patients were regularly coming into the clinic. But also it was over 36 months, we had an annual survey of the clients, and among other things, we had a scale that asked about social support, about depression, about feelings of internalized stigma. So we were also interested in some of the psychosocial outcomes as well. So, Vera, sorry, I should turn it back over to you.
I'm kind of interested, Alan, and anyway, if Tibebe and Vera are able to answer, it'd be great. But I'm still a little bit vague as to what sort of the motivational interviewing bit consisted of. I mean, I assume that these are community support workers. I assume they're sort of, as you say, they're people from the community. They themselves are HIV positive, like a community health worker, really. So, you know, what is it that you actually train them to do, you know, that, you know, one could sort of label as motivational interviewing, other than just sharing information, giving knowledge, you know, liaising with the clinic, offering support and so on, all of which of course are also important. But I'm just, yeah, I'm wondering if you could sort of bring that into focus for us.
Actually, this motivational interviewing involved from the beginning. The support workers actually tell their stories to the client patients. They describe how they were having serious illness and how they came to learn about their HIV status and how they came along to be well, and they started by telling their stories, and usually they have to discuss. You know, at the beginning, it is the health care provider who actually sends the patients to the support workers, and once they meet, they have to tell their stories and how they come to be their present status, and they have to conduct the discussion at the discretion of the patients. It is the client who actually selects where these support workers and the patients were going to meet, and it is the selection of the patients where they meet, and they actually discuss with positive attitudes. You know, during the training, we actually give them some sort of communication, how they have to communicate with the patients. Therefore, they are expected to be not to be judgmental, and they have to show them hope. They have to start the discussion how patients living conditions look like, their family members, what kind of families they do have, and what looks like their living style. And based on that, they show them some circumstances that they can live well with their treatment, and they also give them some sort of hope so that they can support their families and live like people. And it is based on their personal experience that they actually educate and counsel the patients. Most of the patients, you know, like in other places, they actually have fear of stigma and discrimination. And this fear of stigma and discrimination is not actually for themselves, but also they have such fears for their family members, particularly for their children. Therefore, they discuss what is the frontline problem of the patients, and based on that, their type of problems they discuss, and they give or show them how to deal with their challenges, and that is how they used actually to deal with the patients, and that actually motivates the patients, because they give them hope how to deal with or how they are going to support their families, and they actually counsel them that they can also live like other people. And it is based on individual patient circumstances or challenges that they educate and counsel them.
That was a wonderful explanation. And Bob, you know, if just to add one to what Dr. Saleh has really nicely summarized, you know, in the initial training, we did, one of our psychologist co-investigators did sort of formally present motivational interviewing and the principles. And then as part of the initial training, we had them do some practical exercises, but very much as Dr. Saleh has said, it was really, I think, much more important was sort of the spirit of motivational interviewing and working with clients around issues like disclosure and stigma and all the other really important challenges. And that was sort of an ongoing process, which was reinforced at all of our support worker interactions.
I see. One last question, Bill. You want to?
I was just going to comment. That's a real interest for me of what are the essential or what are the most important elements of MI in this context. Certainly, the non-judgmental spirit is a piece of it. And what was it that the workers were conveying that seems to make a difference? Because as MI crosses cultures, we begin to ask what stays or what is the essence of it here that really makes a difference. I was asking about the follow-up workers also because in our research, we find those actually are therapeutic agents often, that they're staying in touch with people over time, and that's actually a part of the intervention.
Absolutely, yeah. I don't know, Tavebe or Dr. Saleh or Abera.
I think, you know, most of the patients have a serious fear of stigma because they feel that their confidentiality will not be maintained, and other people may know about their status. And one of the basic principles that the support workers have to follow is to express to the clients that their secrets will be maintained, and they have to, they assure them that they will keep the secrets of these patients, and they would not disclose unless they give them their permission. And that is one thing. The other thing is, you know, patients usually do have fear of their family members if they are found, they found that their status is disclosed. And these support workers are expected to ensure that they would not disclose this even to their families without their consent. And after some time, actually, most of the patients want to disclose to their families, and these support workers provide support on disclosing to their families. I don't know if I responded well to your question, but others may.
I think to Bebe, I think there's one person in the call, Memong Fabian, who has put his hand up to ask you a question, and I see that Goodman is saying we should ask him to ask his question. So Memong, go ahead. You have to unmute, put on your video, and ask your question.
Memong is just coming over to the panelist, so he should be joining us now.
Oh, okay, okay.
And you know, while he comes over, I'll just add that, you know, I can't how incredibly important it was that the support workers were also HIV positive themselves, because so many times we heard that support workers would share with clients their own personal stories and by virtue of being able to share their own personal stories, really allowed them to establish a sort of communication. And I understand how it's been because I have walked in your shoes, so to speak.
Is Mimon with us? Or oh, there he is.
Hello.
Yes, go ahead.
I'm Mr. Memo in Cameroon.
Welcome.
Thank you. Thank you. I'm very happy to attend this appointment because the problem of consolation in Cameroon means that the family are going to be responsible because our patient was very, very young. First, they are very young, and you have the social situation who are not going to speak about consumption of drugs for the young. I am the one of the Ministry of Health who are going to see how you can make something to help family to take care of their children about concerning consummation. Now, if you have all our country in Africa to promote education, to ban it in our association is very good. This is my participation now.
Okay, and I didn't really catch. Was there a question for Tibebe in that?
You say?
Was there a question for Tibebe?
I think it was more of a reflection.
More of a reflection, yes. Yeah. Okay, thank you.
Thank you, Mamon.
Okay.
I think we'll thank you so much for joining us, and we appreciate your contribution today. So I think we'll hold it there for now with the Ethiopia group. And I'm going to ask our colleagues from South Africa to switch their cameras on, and Ellen, Tibebe, and Abeda will come back to you in the Q&A session in a moment. So our colleagues in South Africa looked at, they did a project evaluating a training program for primary care providers who were offering brief behavior change counseling on risk factors for non-communicable diseases in South Africa. So I think the challenge I'm going to give everybody is to have shorter titles for your papers.
And Goodman, would you mind if I just interrupted you and provided a bridge from one study to another?
Please do.
Just a couple of reactions to what we've just heard. I mean, I think it's a remarkable study, given the difficulty and the challenge of engaging people to come into clinics in HIV. I think it's a remarkable study. And it would be a great pity if the experiences that we've heard here today were lost. So when our colleagues write this up, do let us hear about what those experiences were. I've get the impression that, Bill Miller asked the question, well, how did MI help? And I think Bob asked the same question. The impression I'm getting is that MI is like a springboard for this very high quality work. And just the image of a springboard comes to mind, because what they were dealing with was actually very complex and much more complex than many of the challenges that we come across in other studies of motivational interviewing. So that idea about it feeding the community health workers with a framework that just gives them a springboard for having helpful conversations. If you find it makes an impact on engagement and attendance, I think it's phenomenal. And, you know, I'm really fascinated to hear about what's happening. Finally, in thinking about dear friend from Cameroon and all of you, please be mindful of how we might help disseminate this study, and be aware that there's an organization called PATA, which deals with pediatric and adolescent AIDS, that is connected to probably 400 or 500 clinics across Africa. And I used to direct that, be a director of that. They will have open doors when I come and, you know, if I can help you get your study into their understanding of how to help community health workers. So I think it's a wonderful study. Thank you for your inspiring presentation.
Thank you, Steve. You're very right. I myself can't wait to see the write-up and see what the findings are. I think you'll remember from our work, we've got an attenuated version of MI that we're trying to teach to non-specialists, which we're calling a guide on the side. So, you know, we're far off from even writing up that data. So it'll be interesting to see what's come out of this and how it can inform how we then morph our interventions for the community level providers. So thank you, Steve, for that reflection. And of course, the next level up is the primary care sort of level. And so Zara and Lorraine, I was confused because now Lorraine's name is also Zara on the screen. So I think the first thing I'd love to hear from you, and it sounds strange asking you this because I know you well, could you both sort of give us a sense of who you are? And I'm going to ask Bob to do the same because he's also a co-author on this paper. Just your backgrounds and how it is that you became interested in MI and you know, what led to this work for you.
Thanks, Goodman. May I just note that Liawa is also part of the team, of the South African team. So I think she was on.
Thank you.
Thanks,
there you go.
Liawa. All right. Would you like me to go first, Goodman?
Go ahead. Thank you.
Yeah, so the interest in this is basically that so I happen to be working in the family medicine department of Stellenbosch University with Professor Mash as the HOD, who's of course almost the father of MI in South Africa. And this was leading on from previous research that was more of group, in group counseling. But what we did know from the local research, we knew that primary care providers on an individual level are faced in South Africa with numerous barriers to deliver counseling in primary care. And specifically because of scarce, resources, language, time, also the lack of training. So all of this led to this idea of how do we actually analyze the current situation here at individual level for primary care providers, develop, design, implement, and evaluate a training intervention that is based on best evidence, but also that can be applicable to our setting, which is quite unique. And I think this is where this whole thing came from. And it was a PhD study that involved the whole ADDI process over time. So that's the background from that. And then maybe Buyawa, if you can just. I think you have to
Yeah. Okay, my study actually was just a sub-study of a bigger research project that Bob was doing. I was actually evaluating the community health promoters, evaluating their adherence into the motivational interviewing while they were doing group education to patients with diabetes. Using motivational interviewing, obviously, we evaluated how much they adhere into in adhering in motivational interviewing during these sessions. And of course, we trained them, and then of course we used the validated tool to evaluate them, the validated MI tool, the MIghty tool.
And if I might ask, Wiela, how did you become involved in this work? What was your background and your interest that stimulated you to get connected and work with Zara?
Okay. All right. My background is nursing, and I've been working for many years in the diabetes field. Been working in the field for many years. So I was doing my master's degree, and I was actually looking for a research in diabetes. And I just happened to be in the right department at the right time, and then CDIA. And this project was on, and they were looking for someone to do this sub-study of this big research study. So, and I really liked it because I knew that I was going to learn this new skill myself. So that helped a lot. And yeah.
I wanted to ask, as you were monitoring adherence, what did you find people easily understood and did, and what were some of the more challenging pieces that you noticed?
Well, of course, the health promoters were really very keen to learn this method of communication, but initially they would try their best to try and remember, but now and again they would slip, which would be very easy. If someone asks a question, they would tend to answer the questions themselves and, you know, go back to that mode of teaching. But they were trying their best, I must say. And of course, by the results was that they were not completely competent. They were at the beginning of proficiency, of the level of proficiency.
Of course.
Of MI.
Yeah, I think because Zaura and Buyela are talking about two slightly different but related studies. You know, I mean, Zaura's study actually is looking at training nurses and doctors in, you know, in brief behavior change counseling within a one-on-one consultation. And Buyela actually is talking about health promotion officers who are actually also a bit like community health workers, facilitating groups of people with diabetes to also change, obviously, their sort of self-management and self-care. But the two obviously complement each other within the primary care space, and that was kind of the intention. And I think that, I mean, I think in South Africa, the challenge we face is that we have huge numbers now of people with chronic conditions. You know, we've got the HIV epidemic, which we heard all about just now. Of course, it's also huge in South Africa, and TB with it. And now we have, you know, also this huge burden of non-communicable chronic diseases on a health system that is very scarce and limited, sort of both human and other resources. So the challenge is, how do you cope with the sort of avalanche of people with chronic conditions who all need to understand their condition, change their behavior in a lot of cases, but how can you do that with the few resources that you've got effectively and with quality? I think that's the sort of almost challenge in a nutshell. And so Zaura is sort of saying, well, we can do brief, you know, behavior change counseling in the consultation, and maybe we can get primary care providers to do that well. And I think Zaura's work showed that they're not even trained really to do it well, I mean, previously. And Buyela's study was saying, well, let's get groups of people together and try and help them as a group, because there's just so many of them and they don't get anything individually. So yeah, that's sort of the background in a way of why this is relevant in our context. Yeah.
Also, if I can just say something, I was also trained by Zaura in that as a healthcare provider in her study. So I was also a participant in Zaura's study. And once, after some time, I also co-trained and assisted, you know, a bit, yeah, with training as well.
I think what's interesting for me, you know, Buyela talks about the difficulty of teaching an old dog new tricks. And one of the core features of this study is that you've really anchored it in the 5 A's. So you're giving the new skills a structure that they can be carried in. I wonder, you know, as you talk more about the sort of the detail, I wonder how that was received. And I wonder if people understood that, you know, the whole idea of MI is a whole different way of communicating, or do they see MI as an intervention in itself? But asking that question, I'm aware that Lorraine also hasn't introduced herself yet.
Okay, so Goodman, maybe if I can just answer that question and then Lorraine can. So just to, the training that we did for the doctors and the nurses combined three basic aspects. It combined teaching the spirit of motivational interviewing, focusing on autonomy, compassion, collaboration and evocation. And then the second one was the skills, the OR skills, the second bit. And the third bit was the 5 A's. Which was interesting is that we linked the spirit to each of the 5 A's very clearly during the training. But really because we recorded participants before the training with a standardized patient with one of the risk factors. And what was interesting is that most of them actually did the 5 A's, but they did it in a very directive way. Do you smoke? You should stop. You could hear it, but it was not. So the change was really getting the guiding style into what they were already actually doing unconsciously. Unconsciously. Sorry, Lorraine.
Yes, and I've noticed as well, just to shift from a very directive approach to a guiding style, that was a huge paradigm shift that people would have to go through. And some people are more inclined to fall into that more client-centered, patient-centered guiding style, and others find it a lot more challenging. So often when you're training a group, there are some people in the group that will just naturally fall into that because they've got an inclination towards being a little bit more contemplative in their approach, not in a little bit less of a rush when they're communicating with their patients. And when training those groups, you can often see that there's a mixed receptivity amongst the group. So I've been involved from a training perspective right from the beginning. When Zara first came onto the team, we've worked together in motivational interviewing and have been involved in this project in the side as a trainer, not as a researcher. But yeah, that's it. That's what I have to say on that. It's been very, very interesting to see how BBCC has been received and training BBCC and also training motivational interviewing and seeing the same challenges actually arising when training participants in motivational interviewing or BBCC, is that there's the same difficulty in shifting from being very directive to being more guiding in the approach and really embodying the spirit of motivational interviewing. And that's what you're saying, Goodman, is teaching an old dog new tricks. And that shift, that paradigm shift, is often most challenging.
What did you find helped people make that shift? Because that is a fundamental one, from being in charge and making change happen to calling it forth from the person that you're trying to help.
You know what, honestly, I found that the more I could connect with the participants and really understand their perspective, that often they were so burnt out, so depersonalized, and so detached from their role as a healthcare worker. Within the initial stage of engaging with the participants, if I could engage with them and they could feel that sense of collaboration with me as a trainer, it was much easier to model empathy. It was much easier to actually get them to model the guiding style through feeling that sense of collaboration with me as a trainer. I don't know if that answers your question, but that's where I found working with their resistance to actually shift from a directive to a more guiding style. I found that much easier once I had really engaged with them as a trainer. Zara, do you want, or Boyel, what do you want to add anything to that?
I would just add the feedback from some of the health promotion officers in the study that Boyelwa was involved with, was that, oh my goodness, patients come up to me now in the corridor and they ask me questions, they actually think I'm a human being, that is approachable, and there was, so the people experienced, I think, especially the health promotional officers, that when they went into this different way of communicating that they had a different relationship with their clients, with their patients, which was very positive. And I think the other thing is that the directive style, as I think you all know, was resulting in a lot of anger and frustration, and suddenly, you know, having a way of engaging people that didn't take you into that very frustrated, angry, confrontational space where you felt like you weren't, you were doing everything that you should do, but it wasn't working, and people didn't listen to you, and they should have listened to you. You know, that getting out of that space also helped people to actually feel less negative about themselves, actually. Yeah.
Yeah, and if I could add, it's quite interesting that when we measured the MI adherence in the beginning, the group, which was mostly nurses, which had the lowest MI adherence before, had the biggest shift, which was so rewarding. So that was also very interesting. And I think because we followed them up in actual practice 6 weeks after the training, because we did a qualitative evaluation as well then, and one of the things that came out that is actually so sad is that besides the fact that they have now shifted into the guiding style, the circumstances around them and the system remain the same. So this, you know, forced them to almost default back to the directive style. So that is also very interesting. So just wanted to add that.
Yeah. Okay. I think also, if I can add something, during training, it was interesting to hear some of the people during training, when we showed them the video of the directive style, some of them actually thought that was the right way of doing it because that's what they knew. And then only after, you know, and only after they've seen, you know, then we give all the lectures and we talk, and then once they see now the video on the guiding style, and I think that helped for them actually to actually see the difference. And the other thing that helped a lot of people to shift or help them adopt this new style of communication was practice, doing role plays and practicing bits of skills at a time, and then eventually they managed to get it.
Yes, that's very true. We gave the evidence, then we modeled the skill, then they practiced, then they got feedback, and then they reflected. That was very true. That helped as well.
And what you were talking about, Lorenz, sounds like, as a trainer, doing the very thing that you're trying to help them learn to do. Yeah. So you're showing it.
Yeah.
Without saying so, you're showing them this way of working. Yeah.
That's what we try to do.
Well, of course, of course.
Thank you, guys. There's much to reflect on there. So thank you for that. You know, Steve, I know that you don't want to say anything, but do you have any quick reflections before I tie up and move on to the next group?
It is just so much in these accounts, and I was dying to ask all the participants, if you could change one thing in the development of motivational interviewing, what would it be? And I asked myself that question listening to you, and for me, I started wondering about the education of practitioners in their colleges and schools where they learn. That's maybe where we've got to start. But anyway, that's just a wild thought, and I'll hand it over back to Goodman, knowing that we might grab some time to discuss this sort of thing later.
I think, you know, part of what we try to do through our teaching at the postgrad level is we are hoping there'll be some sort of trickle down through modeling and sort of practical exposure to some of the techniques we teach. I think there's been some exciting developments locally, certainly, where there's additional interest amongst folks who are training specialists in making MI more of a present and consistent skill, as opposed to something special you read in a textbook in 5th year. And I think that's kind of what you want to try to achieve, is a culture change towards more of a collaborative style as opposed to paternalistic. It's that shift that we really are just grappling with constantly. I see the question, Sarah, and we'll come to it. I want to make sure that we give Moses enough time. So Moses and his colleagues in Uganda did what, for me, is really, so most of our work in my group is focused on substance use disorders. So it was great to read a study that's focused on changing risky sexual behavior. So Moses and team did a study looking at the effect of motivational interviewing-based counseling during outpatient provider-initiated HIV testing on high-risk sexual behavior in rural Uganda. So Moses, please tell us who you are, tell us who your team is, how did you get interested in this, and how did you get involved?
Yeah, thank you very much. And my apologies, my colleagues are not able to join this morning, but my name is Moses Bateganya, and I'm a physician. I work for FHI. I'm based in the US now. And my colleagues, Susan and Rhoda, Susan is also based in the US, Rhoda is based in Uganda. We met a couple of years ago, and I think we were at one of the AIDS conferences, and Susan then was into some behavior studies. I was an HIV provider, and Rhoda was a public health expert. So we started a collaboration to really look at how we could change or integrate research into routine practices. So this was a couple of years ago. The paper was published, and I think we can share. And since then, we've continued to work on this collaboration. So really what we wanted to do was, at the time, HIV counseling and testing was changing. The WHO, because so few people knew their HIV status, WHO changed because remember, we were focusing on voluntary counseling and testing, where people came in on their own and asked about HIV testing, depending on whether they suspected that they were infected or not. So at the time, to increase those numbers, WHO issued guidance which changed from VCT, although VCT still continues, to ask providers to offer testing and then some bit of counseling. The focus was mostly on people who tested positive. So the goal was really to focus on those who tested positive, link them to treatment, and very little was done for people who tested negative in regarding change of behavior and so on. So I think we were trying to see how we could take advantage of the fact that with this PITC, a lot more people were being tested, but counseling wasn't part of the package because of time. I don't know how many of you know Uganda or some of sub-Saharan African countries. Of course, the outpatient department is a very busy setting. So if you're going to provide counseling, there will be many hundreds of people. So what we thought we would do is we would sort of give PITC as it is intended, but then add a component, a modified component of counseling that was based on motivational interviewing to participants who had just been tested. So that is what we wanted to test. So we basically designed a study, a historical control study, in which people who received PITC, we assessed their behavior before they got PITC, and then 3 and 6 months, asking about behavior that were considered unsafe, which is having sex with a partner of unknown status or discordant status. So we did those interviews at baseline, 3 and 6 months for the control, which were typically what PITC was then in Uganda, is that you get a few minutes of counseling and then you go home. If you're positive, you get linked to the ART clinic. If you're negative, well, you're told to go away, but nobody really knew that behavior would change. So through that, we had the control. And then to add on motivational interviewing, which we assumed would help participants change their behavior, we added on a modified motivational interviewing component into the PITC. So as I mentioned, the window was really small, that between being counseled and tested and getting results is about 40 minutes. And if there are 100 or 200 people waiting in an outpatient clinic, you need to fit that intervention within their time, and not say that you have hundreds of people waiting on you to give them motivational interviewing. So we modified elements of motivational interviewing and gave participants who had just been tested a session, a 10 to 15 minute session while they were waiting for their results. So as I mentioned, this was a historical control, and we basically enrolled the control, waited for a couple of months, and then enrolled the intervention. And then we compared those two groups to see behavior change for individuals who were in the control and in the intervention. So that is really the basis for this study. Oh, you're muted, sir.
Yes, thank you. So I think, as you were talking, I found myself asking myself the question whether the need to shift from VCT to PICT in the first place doesn't already reflect a shortcoming in our messaging in the first place, because why is it that people weren't coming to get tested? And why is it that folks who did come to get tested weren't staying on treatment and achieving viral suppression? So, this is a criticism we can debate at some other stage in terms of what the focus is of interventions and funding, because, does one then interrogate why it is there's a failure, or does one then try a more, what someone might argue is more paternalistic, which is a provider initiated sort of approach. So I think what we also know is that we've fallen short of the 2020 targets, in South Africa, on the continent, and worldwide in terms of HIV. How do you think that, in terms of motivational interviewing and in terms of the work you've done with PICT, do you think we missed the ship? Should we have gone back and said, what are we missing in terms of providing motivation at the outset before introducing something else and then adding MI to that? I hope it's not too complex a question.
No, it is not too complex, but it's a good question. And I think the push to get to the first 90, I think, shifted people away from really focusing on helping patients make decisions, making good decisions. So as you mentioned, we are paternalistic. Somebody comes in for testing, they tell you they have, in Uganda, polygamy is practiced, and in this particular area, people had, polygamy, couple of wives, maybe. And then you sort of prescribe and say, you need to reduce the number of sexual partners. And then you send them out of the way. So that push, I think, moved us away from the first principles, which was really, how can we help people make decisions? And we continue to make those mistakes. After testing, then you tell people, we are starting you on treatment, without that kind of discussion that is critical for the person to get engaged. You sort of test them and tell them you're going to send them to another place to get treatment without critically talking to them about anything. And I think the failure is really for the way we communicate and the way healthcare workers are trained. Is like, we prescribe, we suggest, we propose. So I think MI needs to go into all elements of communication between healthcare workers and their clients or their patients.
Yeah, I was going to argue. Yes.
Yeah.
I was going to argue that maybe PICT and MI are opposing forces, but the counter argument is that if you use MI principles, then the PICT itself can be made more collaborative as opposed to paternalistic. So I'm arguing with myself,
yeah.
so there's no need to engage me. Steve,
yes,
do you have any thoughts to add to that?
What's PITC?
Oh, sorry. Yeah. So PITC is provider initiated testing and counseling.
Got it.
So, and the change was really, initially we were doing provider initiated, people came on themselves and were counseled and then they got tested. That counseling session took 40 minutes or so. And then you made a decision to test.
Yeah.
And then the counselor talked to you again for another 40 minutes.
Yeah.
When we changed to PITC and there were hundreds of people being tested, then that counseling sort of, went away. Yeah. The people who were positive, definitely we would find them in the HIV clinic. People who were negative, honestly, when we changed to PITC, they did not have any other opportunity to discuss their behavior or to be, referred to any other community resources.
Yeah. And I'm asking myself this question: what is the place of motivational interviewing in these systems? And it's like the system has been set up, let alone the training of both the training of practitioners and the system is set up, and it ignores the fundamentals of good human connection and caring. And I suppose that's how I see the problem. And it boggles my mind to try and think about how to resolve that, and this is extremely elegant what you've described, and I'm really looking forward to reading about it and learning about it. But I'm left with this overriding feeling that the humanity has been sucked out of the training of healthcare people and the delivery. And we're a bunch of desperados trying to breathe humanity back into it, using really difficult research methods as well. That's another whole discussion. I think the research methods that the scientists are using are so clumsy and difficult for people to execute that I'm just in awe of what you describe you doing, and I look forward very much to reading and hearing about it.
Thank you. So I think I can quote other examples. So option B+, pregnant women tested for HIV, given their results, then given treatment. So all of these areas, I think, miss the critical human connection, where a midwife sits with another woman. They talk about the things that are going to happen over the next 12 months. Instead, people, I think, during PITC were given information as a group. You stand up in the outpatient departments and tell people about HIV. It's a virus, it causes X, Y, Z. And then you send one by one to go to the lab to get tested. So I think what you're talking about, and I think what the group is doing is really what is going to help us to change the dynamics. And I think we are seeing some of the side effects of shifting and taking the human element out. It's like we start people on treatment and they throw the pills out the moment they leave the clinic because they never had that intervention.
Moses, I think you did indicate that, in fact, you had finished the research. And so I'm just wondering, what did you find? I suppose that's basically the question. At the end of the day, what did you find in your outcomes?
So first of all, I think we were testing two things. So first of all, that would you be able to add an MI intervention in the limited time in a busy clinic and be able to deliver that. That we found that it was feasible to add a modified MI intervention in a busy outpatient clinic and still deliver that intervention within the time between patients get tested and waiting for their rapid test results to be available. Now, when we compared the two groups, so we compared the people who got PITC as a standard of care and then the people who got MI, and we found that sexual behavior, risk of sexual behavior reduced in both groups. But the reduction in the MI group was higher. So in the intervention, people were 1.5 to 2.4 times greater decreases in high risk behavior over time. So to us, that was the key findings, that this MI intervention was better than the control.
And I got the impression that the intervention was regardless of whether you tested positive or negative. Am I right?
Yes.
Yeah. And so was there any difference between the behavior change in those that tested positive versus those that tested negative?
Yeah, I think there was behavior change in both. Actually, both individuals, and I will sort of look up the actual differences.
Go read your red paper now.
Yes, this has been a couple of years ago. It's like when Subeko asked us to talk about it, we were wondering, that this is kind of a couple of years ago, but there was change in both, and I think literature already shows that positive people already changed. I think the question was whether people who tested negative, who typically don't get additional counseling, would change. And I think we were more motivated by those results, that the people who tested negative actually changed their behavior. Now, I think the caveat is that, of course, we were trying to explain why people who never got MI based intervention also changed. But that change was not as sustained as in the people who got the motivational interviewing. And I think the other caveat too was that we followed up people for about 6 months. So we did the baseline, we did the 3 months and 6 months. So again, we don't know. And this was a small study, one site. So we didn't know how long this behavior change would last. Of course, a lot has changed between then. There's now PrEP, there are other things. But I would say that, I think we were able to show in our findings that motivational interviewing is something that can be added to standard testing to reduce behavior.
I'm going to give Bill a chance if he wants to chip in here. Yeah.
I guess what strikes me is that we're asking an awful lot of relatively small interventions, both with patients and with systems, that we hope that a few minutes of person-centered contact will change behavior and ongoing lifestyle. And what's amazing is that happens sometimes. And that a little bit of motivational interviewing sprinkled on top of a very autocratic healthcare system is going to change the outcomes of healthcare. So the fact that we see a signal, to me, is encouraging. And I think I get that over and over again, that somehow even a little bit of motivational interviewing with a patient or with a system sometimes is enough, sometimes has that kind of impact. You hear your patients beginning to respond differently. You're surprised that they're coming and asking you questions and doing things. So what's happening there? What is the essence of it? I wrote a paper a while ago on small interventions and large effects, and somehow there's something powerful happening here, but it can, as Steve said, get lost in the research design as well. I mean, we're testing whether the MI group looks different from the usual care group. Well, did the MI group actually get any MI? We don't know necessarily. Some of them got some MI. And if in those conditions, you're still finding that you get more change and it's more enduring, that's pretty amazing to me. So we're asking a lot of small, relatively small interventions within an overwhelming context of the patient's life or of the healthcare system within which we're working, and trying to understand what's going on here. What is it that clinicians are learning that seems to help them make that shift, and how is that affecting patient behavior beyond these relatively small interventions that we're delivering? That's pretty amazing. The self-disclosure aspect of the first study we heard about was interesting too, and it's something we haven't emphasized much in motivational interviewing. And yet it's something there's a literature that at least certain kinds of self-disclosure really can humanize healthcare and make a bigger impact. So I'm coming away with many more interesting questions that come down to what's most important for us to convey when we're trying to teach motivational interviewing to providers who are used to taking a kind of paternalistic, directive, I'm busy and I'm in charge here kind of approach. It's complicated stuff. And the hope is that even in the midst of all those complexities, we're still seeing a signal. We're still seeing that something is happening.
Thank you. I just saw, I think, a comment. Unfortunately, I can't read all the comments, but I just saw, I think, a question flash about culture. And I just wanted to explain that part. So Uganda, definitely the English is the official languages, but there are multiple other languages. This area of the country where motivational interviewing was conducted, talking about sex and sexual behavior is kind of quite taboo. And I think translating some of the MI principles into the local languages and discussing, and so it was quite complicated. So we have a 60-page protocol for the counselor. We had a 4-day training where the counselors were sort of, how do you ask about sexual behavior to somebody who said, they are married, they're 60 years, and culturally you're not supposed to talk about sex. I mean, people in Uganda, I think, rarely talk about some of these things. So I think you are just highlighting, I think some of the comment highlights some of the challenges of translating MI principles into a culture where some things are taboo, and don't ask about anal sex. So, I mean, in Uganda, probably if you had a questionnaire that included anal sex, people would sort of. But in this study, we asked about this because this was sort of things that had to be answered. But it's a complex, I think, to integrate MI as it should be into standard practice and for people to understand. But I think for me, any element, any discussion between the provider and the client might actually just be catalytic and cause a change which is difficult to predict or quantify.
Mm-hmm. Mm-hmm.
Yeah,
I think where my question came from, the folks who are attendees may not have seen my question. I asked Moses, how does culture factor in? Steve and I have had these conversations about, how exactly do you help somebody who is not used to having a power position in a deliberation about their healthcare? How do you get that person to become a collaborator? So that's a deeper level of shift. And I think as we think about our activities we're trying to achieve with the work we're doing in Africa, about creating a collaborative spirit, that's something we'll have to deal with. The whole idea that Western medicine has the answers and that folks are there to receive direction and treatment, as opposed to there to bring their own perspective in terms of what needs to happen next. So that for me is an important part of the shift that needs to be part of how we're thinking.
Yeah, and
I think, go ahead, sir.
No.
Go ahead, Moses.
No, I was going to add that typically people are not used to talking with the provider, and that people would be surprised that the doctor talked to them. I think you can see this on the medical ward. People are doing a ward round, they teaching students, going around with students, and telling them about the condition, minus talking to the patient who they are talking about. So typical, I think this is, I think, a culture change that needs to happen, so that there is at least a discussion. It doesn't matter, I think, what the content of that discussion is, but the fact that there should be a discussion between a doctor or a nurse, a community healthcare worker, and their client is enough, I think, to cause the beginnings of change.
Can I ask a question? I think one of the things that Moses mentioned early, which is also just the practical reality of working in these clinics, you have many patients in very, very limited time. And so, you may have so many patients, maybe you have 5 or 10 minutes with a patient, and you have to ask about side effects and so many different things. So I guess one of the questions is, how do you sort of integrate that into a busy clinic where you really don't have very much time and a lot of pressure to cover a lot of things with clients, many different clients who are waiting?
And Alan, you bring up a very good question, but I think what we forget is that people would have been waiting for 3 hours, and then they spend 5 minutes with the provider, and then they spend another 2 hours at the pharmacy, and waiting in line to be served. So I think basically what we wanted to take advantage of was that window where people are waiting. It takes, I think at the time the rapid test we were using, had 15 minutes, or I think you needed to wait for 15 minutes for the first one, and then another 20 minutes for the second. So between that window, if a research assistant comes to you and say, I need to talk to you about something, before you knew your results, you are very receptive at that time. So I think we need to take advantage of the client flow and look for opportunities. And now we are pushing index testing. Anybody who tests positive, their directives are you need to get that person's sexual partners. Write them down. Ask that person's, but in a busy outpatient department, how do you do that? How do you find the space? So I think we look for these sort of wasted time in clinics where people are waiting forever to see a doctor. Use that time before, use the time after, but also structure some of the intervention. And I think, as we found in our study, that it was difficult for the counselors to fit that, we had 8 steps. You make sure you do this, make sure you talk about, make sure you did. We actually recorded some of those interviews to see how easy it was to follow, and it was difficult. Alan, I think this is a challenge, but I think it is something that can be solved. Like, how do we use those 10 minutes effectively with the client, and then the wasted time they are waiting to do other things that might not be related to the main reason they are seeing the doctor for.
I feel like it's important to also reflect that the reason we're talking about the time consumption is because we're talking about MI in interventions, because we haven't managed to create the culture change so that it's just a normal part of communication. So that's part of what I think we have to keep in mind, that if we're successful in shifting the style of engagement to a more collaborative one, then we're not talking about an intervention. We're just talking about the normal course of how things should go. I know Nurain, Steve, go ahead before Nurain comes with those questions.
Yeah, I've got one reflection from an old dinosaur who looks back and wishes he'd done things differently, and I thought I'd share it with you. And I think Bob Mash will probably go, oh no, why didn't we talk about this 20 years ago? Which is that we presented MI as this very patient-centered process, which of course is going to be difficult to integrate into the kind of environment that Moses has so beautifully described. But if I could wind the clock back, I would have started somewhere different, which is, what does humane and skillful advice giving look like? Because I think it is very compatible with MI and is perhaps a more useful entry point for busy practitioners to learn. For sure, you might want to learn about MI or BCC or whatever, but for these practitioners to deliver information and advice in a humane way, that's going to be more effective anyway. And I believe we've achieved that, and I've written about it in the latest edition of the MI in Healthcare book. But I wish I'd been as clear about this 20 years ago, Bob. But I'll keep quiet now because I can see the time's winding down. So there's a reflection from an old dinosaur.
Dinosaur or sage? I don't know, you choose. Nirain, so we've got 3 questions. You can pick the order you want to ask us.
So I think we had the question earlier on from Dr. Busi, and it was with regards to, I think, sort of COVID in the sort of, yeah, the MI in current COVID circumstances, and what role MI can play in this sort of setting, and, you know, the requirement of motivation at community level.
Yeah, and I've since been corresponding with Dr. Busi, and he and I are in contact on email, and we're going to discuss this. How's that?
Awesome. And then I know there was a question a little bit earlier on as well from Sarah, and it was around being a psychological counselor in a correctional facility. And it was specifically that she'd like to know or to have a picture of what potential outcomes of using MI in that population group.
Sounds like a question for Bill and Steve.
Yeah, certainly in the addiction field, we see lots of people referred in from the correctional system. And also the MI is starting to be used in the institutions themselves. And Steve's talked a bit about that as well. I mean, it's a way of doing what else you do. It's a way of delivering the services that you have. And my experience is that when people are being coerced, this is an even more powerful way, because it's so focused on the individual, so respectful of their autonomy. So by all means, try this out with in correctional settings.
Yeah, a couple of weeks ago, I ran a training session for 50 prison officers. They were all young, 50 prison officers, and it's brutal out there. And I think, as Alan Lifson has pointed out, the training inevitably started with their well-being. Okay, and so I think MI has been used in this kind of facility, and I bet you there's some studies which will show that it's been effective, but you come across precisely the same cultural forces, probably ramped up in that kind of setting. They're ramped up, they're more extreme, there's more brutality around. And I don't know the context in which the questioner lives, but I wouldn't like to be starry-eyed about motivational interviewing. Certainly in your own personal work with people, if you're a psychologist, that's brilliant. But I appreciate you're up against a brutal system, and MI is not going to solve that one.
Thanks. And I think the one last question is from Ruth, and she's saying that she's quite new to MI. And as a coach to about 20 children between the ages of 4 and 14, she'd like to know how MI can be used in education, as a foundational installation that will facilitate the effect of the application of MI in later life of the child if necessary.
Steve, you wrote a book on MI in schools.
And then sport, and I think it's got fabulous potential, and it is compatible with movements in education that are much more stronger and person-centered, like the restorative approach, which is widely used in education. So I think good teachers know what guiding is, and I think MI is a beautiful, perfect fit in education.
That's awesome. So I think that's all the questions that we have. I would love to stick around, but I do have to drive for my 6 o'clock meeting after this. So I don't know if there's any closing sort of reflections from, but I want to just first start by saying thank you to all the panelists for making time to join us today, and welcome to the MI in Africa family. We're going to bug you because we're going to keep this ship moving forward. So we look forward to keeping around and keeping the conversation going within the group, and sharing new works that evolve, that we discover with our growing family. So I don't know if there's any closing reflections from anybody else.
I think a 30-second reflection, and I see my battery is also running low, so it might literally be 30 seconds. Yeah, one of the cross-cutting themes across all three was, like, we're dealing with limited time, limited resources, scarce human resources, and we're trying sort of small adaptations of MI with often like community health workers and people who are not sort of these highly trained professionals with multiple sessions and bags of time, and that seems to be our reality in the region, and we've all kind of been focusing on solutions that look like that, and that sounds very appropriate, but we probably need to reflect a little bit more, bringing together, these different ways that we've tried to do it, and see what it tells us about what is appropriate in this context.
Completely agree. And I look forward to further discussions in the MI in Africa webinar series, in which we address exactly what Bob has challenged us with. And Goodman, although you've got to go, I'm happy to just hang around and deal with any, and respond to any further queries. I know that it's 3 minutes past the half hour, but Angela, if you leave us on for a while and just give us some time if there's any remaining folk who want to chat. But Goodman, you need to go, so yeah. And
thank you very much.
Thank you very much, Goodman, because I know you're working incredibly hard at the moment, and so thanks so much for everything.
Thank you.
Really appreciate it. Yeah.
Bye-bye. Chat soon.
Speak soon, Goodman. Lovely to see you, Buyelwa. Notice how quiet Fergus has been, hey? Somewhere in there. Anyway, if there aren't any, are there any further comments or queries from folk?
No, I think there's no other questions for now.
What about the next webinar? What should that be on? Shouldn't it be on what Bob's just raised? I'm beginning to wonder. Yes, Fergus, I know you're on as an attendee. I just miss seeing your face and hearing your lovely voice. But I wonder whether the, Bob, whether that couldn't be the subject of the next.
Yeah, I mean, it certainly could be some sort of reflection on that. Yeah, I think something to discuss with Goodman, and I don't know what he had in mind.
Yeah.
Yeah.
We can. Yeah, wise. Time to reflect.
I'm also going to leave you guys, but very nice to see you all, and take care. Yeah.
Soon, Bob.
Cheers, bye-bye.
Bye.
I also like to say goodbye and thank you for my panel as well. It was
Cheers.
seeing you on the computer. Thank you.
Lovely to see you, Delra.
Thank you all. Thank you.
Bye.
Thank you, bye.
Okay. Well, right. Okay, I think it's time for me to go also.
Yes, okay.
Bye, everyone.
Bye,
Thank
Buyel.
you.
Lovely to
Thank
see
you very much.
Thank you.
Bye, man.
Thank you.
Me too. Thank you, everybody. Lovely to see you all.
Yeah,
Keep
bye.
well.
Bye.
Bye. Thank you.
Bye.
Okay, I wonder if there's anything else anybody wants to say. Caleb, you've also been incredibly quiet. It's a disgrace. So next time we're going to have to get you more involved, Caleb. Okay. Because if anybody knows about the systems, it's Caleb.
Well,
Okay.
I'll also say goodbye and thanks, and I hope we can keep in communication.
Yeah, well, we'll hope to pull you into the next webinar. You know, keep involved, Alan.
My pleasure. I'd love to. That'd be great.
Thank
you,
Alan.
so much.
Yeah.
Thank you.
Okay, guys, I think we're more or less done, are we?
Yeah.
I don't think there's any more questions or.
No, I think we're all good.
All right, and Lorraine, thanks,
Pleasure.
Yeah.
Thank you very much, Lorraine. Thank you.
Pleasure.
And Ange, thank you, because I know you've been a rock behind the scene for getting this all together. Thank you very much.
Oh, my pleasure to be a part of it. It's an honor. Thank you, Steve.
All right, catch you later, Ange. Okay.
Thank
Bye,
you.
everybody.
Bye.
Bye.